Also to thank Rupert. Of course, if not because of COVID, I would have loved to be on an elephant with Rupert, like how the old days we used to be, or to enjoy the company after a full day's meeting. And I think these are reminiscence of old times of how we learn from each other. And now we survive and live on Zoom, and hopefully the pandemic will be over soon. But I want to highlight that within the Asia Pacific region, there are a lot of key leaders who jumped immediately to basically work on guidelines when IBD was affected during the COVID-19 pandemic. And I can see here many of these sort of authors, for example, like Dr. Uis, Ida Rupert, and our friends within the Asia Pacific region set up together to set some guidelines. And some of the recommendations that I'm going to talk about pertain to some of these work that came out. So the real question is, as a patient with inflammatory bowel disease, when the pandemic hit, many people will ask, am I different? Or is there anything I need to do differently from my spouse, from my family, from my friends who don't have IBD? I think there are 4 areas I really hope to cover today. The first question which patients would like to know is, are they at an increased risk of contracting the virus compared to someone without IBD? Secondly, if they do happen to have COVID, do they suffer more symptoms on top of the fact that they already have symptoms from the disease? And importantly, do IBD patients with COVID-19 have worse outcomes? And last but not least, certainly something we get called a lot is, what should I do with my drugs? Should I stop? Should I continue? And will it be affected, the outcome with COVID-19? So looking at patients with IBD and increased risk of contracting SARS-CoV-2, I think we have a lot of evidence now. And to summarize, when the pandemic hit, me and our good friends from Taiwan, Shu Cheng Wei, which we both have registries of IBD in Hong Kong and Taiwan, we started looking at close to 5,000 of our patients in Hong Kong and Taiwan in the population-based setting. And reassuringly, that was in the early pandemic, almost a year ago, none of the patients with IBD were infected. And many patients got tested and none were positive. But certainly we know that subsequently more IBD patients did contract, the virus. But if you look around other places like in Italy, in fact, they look across and they found 0.6% of patients were diagnosed with COVID-19. And importantly, when they compared with other population, IBD patients seem to have a lower adjusted incidence ratio of COVID-19, and reassuringly, they have similar associated mortality ratio. And now, I think if you look across America, Netherlands, and even in Denmark, there are population-based studies showing us IBD patients have similar incidence of having SARS-CoV-2 compared to the general population, and they are comparable. In fact, in a subsequent study, they found that they might have a lower prevalence of SARS-CoV-2 than the general population. So what we could conclude for now is based on population-based studies, cohort studies from both the East and the West, having inflammatory bowel disease itself is not regarded as an independent risk factors for acquiring COVID-19. So I think we can probably reassure our patients, although there's a possible involvement of the GI symptoms, and current evidence does not support that, having the disease would cause IBD to flare out. But in patients with IBD, it's not just the disease itself. We know that they are on drugs. We know some may have continuation of active disease with malnutrition. Some patients may be obliged to visit clinics to get their drugs in the medical setting. And patients with IBD, like anybody else, also have underlying health conditions like comorbidities, and some of them are elderly. And these, we now know, are the risk factors for having COVID-19. So in the early pandemic, an Italian study looked at patients with inflammatory bowel disease who happened to get COVID, and what are the things that predict whether they have worse outcome. So as mentioned before, active disease, uncontrolled disease, older age, presence of comorbidities, not surprisingly, cause them to have a higher risk of pneumonia and death in these patients, but not their medical therapy. So that was the initial findings that was reported. Now, the second question is, if IBD patients get COVID, do they suffer more symptoms? We now know that the ACE2 receptor is not only seen in the lung, but highly expressed in high abundance in the human gut as well. And when this first published, Herbert Tick and myself started summarizing what we know about COVID-19 and the GI tract. And GI symptoms are actually pretty common in these patients. And the detection of virus in the stool does not always correlate with GI symptoms. Hence, there may be individuals who don't have any GI symptoms, yet may carry the virus inside their gut. Now, the shedding of SARS-CoV-2 virus in the gut has been shown in several studies because SARS-CoV-2 RNA could also be found in the tissues such as the esophagus, the stomach, the duodenum in more severe cases, and it was associated with ulcers as well. And an Austrian study here showed that raised fecal calprotectin in COVID-19 patients with diarrhea indicates inflammation. So the story may muddle us because we know patients with IBD get diarrhea. And now we're also seeing that COVID-19 also could lead to active and prolonged activity in the gut, even in the absence of symptoms. And we were able to isolate some of this virus and found that there was some live activity in them. So the real issue is with the GI involvement in COVID-19, it makes us as physicians a little bit more difficult to decide whether when the patients have diarrhea, whether it could be just the IBD flare or they may have concomitant COVID-19 as well. Because you see here about 12.5 and some studies show up to 6% of COVID-19 patients could present with diarrhea. And in a more recent systematic review by Laurent Parent from France, they look at across 23 studies, over 200,000 patients. And what they found, interestingly, was IBD patients who have COVID-19, they may have similar symptoms with IBD patients without COVID-19, but they have a higher percentage of diarrhea. But currently, the diagnostic therapeutic approach does not differ between these patients. So the implications as physicians for patient care is what one could do is you could test the feces for COVID-19 if these patients come with diarrhea and they worry they may have concomitant COVID-19 to differentiate those who just have an IBD re-exacerbation. Now, the third question which concerns a patient with IBD is if they were to get COVID, will they have worse outcome? This is a talk, an abstract at DDW this year, so that was just a month ago, whereby they reviewed over 78,000 patients across 143 hospitals. And what they found was that the patients with both IBD and COVID-19, they have higher rates of ICU admission, ventilation, and lengths of hospital stay. You could see here the fact that with having IBD and COVID-19 leads to some of these worse outcomes. So a lot of our patients are taking immunosuppressants drug, and does that really affect the COVID-19 outcome? Many of the drugs that they are taking, we know, suppress the immune system, and these are the common ones ranging from steroids, immunomodulator, anti-TNF, anti-IL-23, anti-interleukin, and more recently, the one that's been FDA approved, JAK inhibitor. And a lot of these tend to inhibit the immune response to viral infections. So I want to show you some of the data that was spearheaded by the Secure Group, by Mike Kaperman and Eric Brander, Jean-Fred Cornbell, and Ran Ungaro. And I represented the Asia to help to sort of facilitate some of these work. And I think this registry is clearly very important. A lot of patients who were diagnosed in India, I believe, also were entered in here. The first message that came out from this registry was in the first part, they only had 325 patients IBD with COVID-19 from 33 countries. And what they found across all drugs, steroids, but not anti-TNF, was associated with adverse outcome if patients with IBD were to get COVID. Now, in these patients, they found some with severe COVID-19, some were hospitalized, and some died. And if you look at the odds ratio, what you could appreciate is that systemic steroids lead to an adjusted odds ratio at 6.9 of having worse outcome, including death, including hospitalizations, as well as ICU admission, but not other things such as anti-TNF. Now, this is work presented at DDW just 2 weeks ago. This is a large study cohort from cases of Birmingham. So if you know, they have a community-based study across the population within the United States. And they surveyed close to 40,000 patients with IBD, as well as other immune-mediated disease who happen to be SARS-CoV-2 positive. And they look at the risk of adverse outcome. And lo and behold, similarly findings were reproduced. Patients with risk of adverse outcomes are those who also were taking steroids. So you could see that outpatient steroid use increases the risk of severe COVID-19, whereas the use of small molecules, inhibitors, immunomodulators did not lead to that. So we may be able to reassure our patients who are on other immunomodulators that they are not at increased risk of adverse outcome. But if you look at other drugs across this, what was interesting that from the secure registry that we published together with Mike Kaperman's group, that those who are on combination therapy, so they look at 1,400 patients from the national registry, and they compared them to those who are on anti-TNF monotherapy, but those who are on combination therapy actually have an increased risk of severe COVID-19. So I'll mention a little bit of recommendation later on what you should do in clinical practice based on these data, that you may want to stop some of the drugs if not completely needed. Now, tofacitinib is available in the United States, and some patients with COVID-19 with IBD who are taking tofacitinib may be of concern, but they found that there was no difference if you're on tofacitinib in terms of more severe COVID-19 outcome. And lastly, what about vedolizumab? Because some of the patients with IBD may be on vedolizumab. This is also work from the secure IBD registry. They looked at over 2,000 patients. What they found that the COVID-19 outcomes were similar for vedolizumab users versus non-user. However, if you compare vedolizumab monotherapy to anti-TNF monotherapy, it was associated with a higher rate of hospitalization and severe COVID-19. So there was the raise of the question of whether anti-TNF may, in fact, provide a little protective effect. I think this is speculation across all the data, have not been proven, but the signal certainly is that those who are on anti-TNF monotherapy seems to do a little bit better, or they don't do worse compared to those who are on other biological drugs. So we then published this review article together with David Rubin and Brits Christensen in order to provide some recommendation. So the next few slides then provide you with certain recommendations. For patients who are on 5-ASA, continue the drug, because there's really no risk of increasing having COVID-19 or worse outcome. So for any patients, we suggest that they definitely don't stop the drug. For steroids, as mentioned earlier, because higher dose increase the risk. So what happens is it should be avoided if possible. With rapid tapering, consider bucesonide instead of the traditional prednisolone. If a patient needs to have a corticosteroid because they have a flare, you can consider bucesonide or exclusive enteral nutrition. If they have been in contact with someone with COVID-19, you might want to taper it quickly if possible in order to not let them have a worse outcome in case they were to contract the virus. Now, for immunomodulators, I think the reassuring news is that there's no clear evidence that with the immunosuppressants such as azathioprine, methotrexate, it actually causes an increased risk or worse outcome. And most patients can continue at a stable dose. But we certainly, during the very bad pandemic, we may not encourage someone to increase, the dose. But if they were tested positive and they have COVID-19, you might want to temporarily stop it for the patient to recover, and then you can reintroduce again. For biologics, as mentioned earlier on, you could see anti-TNF appeared to be relatively safe. If you're starting a new patient in the early pandemic when they can't get access to drugs in the hospital, in the United States, some people suggest using subcut dosage, although anti-TNF subcut may not be available all around the world. And some people have really switched from infusions to subcut. If combination is required, as you saw from the data from the secure registry, combination therapy was associated with worse outcome. So if not necessary, you might just continue monotherapy. But of course, if you are in contact with someone who have it, or if you have the virus, then really we have to withhold until the patient clears the infection. For JAK inhibitors, I think the story is similar. Use the lowest dose to maintain remission as possible, which is 5 milligrams twice daily. Avoid to start a drug during the pandemic unless you have no alternatives. And if you are in contact with someone or you tested positive, then consider to withhold it. So it's rather consistent. So in order to summarize this, the International Organization of IOIBD had some pictorial recommendation. Do IBD drugs increase the risk? You can see most of it really was no, apart from steroids for now, higher dose steroids. What about should patients discontinue to prevent? You could see pretty much everything was no for all the drugs, apart again for high dose prednisolone. What about should you reduce the dose to prevent the infection? You can see it's actually none for any of these, although it may be uncertain for combination therapy, but for steroids high dose, yes, during the pandemic, you should try to reduce the dose and taper quickly, but not for the rest of the drugs. What about should you stop if you develop COVID-19? Not for 5-ASA. I think for steroids, for azathioprine, methotrexate, anti-TNF, all the rest of the biologics and combination, the answer will be straightforward. Yes, until they have cleared the virus, then consider restarting. So I think in any patient who have active disease comes to your clinic during the pandemic, you should treat this patient as what you would do when you choose before the COVID-19 era, apart from high-dose steroids if possible. So there are now a lot of recommendations which are very consistent. You can see the ACG, the Crohn's and colitis, the ECHO, as well as now the APAG guidelines tell us that actually do not stop if not necessary and only stop if they do have the disease. So lastly, you could see these are some of the specific advice for steroid. Caution use is important. And data actually may suggest increased mortality and secondary infection. So anything higher than 20 milligrams, not to continue for too long a period. No, the last few slides is basically on how you manage someone in subgroup. Some patients may fall pregnant and they're worried. Are they at higher risk of having the infection compared to someone who's non-pregnant? I think pregnancy should be considered a high-risk indicator for COVID-19. And all pregnant women needs to withhold with all the hand hygiene possible. And once effective and safe vaccines available, and I'm sure Dr. Uy will speak to you about that, they should actually have it. And if the vaccine has been proven to be safe that be administered during pregnancy, then they should be vaccinated as well. For elderly patients, we know is a big problem because they are frail and they are at higher risk. So I would go for monotherapy if possible in these elderly patients and avoid combination therapy. And lastly, ustekinumab and vedolizumab may also be preferred in these high-risk individuals. And pediatric, the young children, of course, right now we don't have a vaccine for them, but children with IBD should follow the same principles as the adults as well. So the general advice, all we need to know, still, even the vaccination, even with not changing the drug, all IBD patients need to be like someone who is non-IBD. Try not to have essential travel, keep a distance, as well as gathering still during the active pandemic. So in summary, I think we now know that IBD itself is not an independent risk factors for COVID-19, but increasing age, comorbidities, steroids are with severe COVID-19 outcomes. And reassuringly, the TNF antagonists do not cause severe COVID outcome, but those who are on combination therapy may do a little bit worse. So if possible, monotherapy if they can tolerate that. And all patients still need to have the vaccination if they can and should exercise social distancing. And for patients who are stable, do continue. There's no reason to stop. The last thing you want is to trigger a flare and they end up in the hospital. But in the very unlikely, unfortunate situation, if they were to develop COVID-19, then you have no choice but to stop the drug, wait for the infection to resolve, and then restart that. And don't forget about 7 potential drug interactions. So I like to say, look, this was in AOCC 2017. A lot of our friends were there. It was sort of happy times. And I hope that in the very near future, we can all meet again in person and not through Zoom. So thank you very much. And I'll be happy to take any questions later.